Good afternoon, everyone. We're going to give just a few seconds for people to file in, and then we will get started. All right. Good afternoon, and welcome to today's Recovery Summit session, Addiction, Trauma, and EMDR. This webinar is part of the Recovery Summit series hosted each September by St. Clair County Community Mental Health in recognition of National Recovery Month. A few quick reminders: today's session is being recorded and will be available on the SCC CMH YouTube channel, probably sometime in October. Please use the chat box for any questions or comments. Our presenter will address them as time allows. For those requesting continuing education credits, please be sure to remain on the webinar for the full session and complete the survey that will be emailed to you after. We're honored today to be joined by Shannon McKeever. Shannon is a fully licensed MSW and is trained in many evidence-based treatments, including eye movement, desensitization, and reprocessing. Welcome, Shannon.
Hi, Christy. Thank you so much. It's a pleasure to be here. So today I'm going to be talking about recovery from substance use and trauma using EMDR. So like for my objectives today, what we're going to look to is to be able to explore what trauma is and how it affects a person, the emotions and somatic symptoms that someone may be experiencing, what EMDR, eye movement desensitization and reprocessing is, and how it works to help trauma, the link between trauma and substance use disorders, and also how EMDR is used to treat people diagnosed with a substance use diagnosis. So that's what we're hoping to accomplish today. So what is trauma? So trauma is, according to Bessel van der Kolk, not the event that happens, but trauma is how a person responds to it. So trauma is really subjective. Two people can experience the same event, and it's how it's stored and how somebody, the perception of the event that creates the trauma in and of itself. So let's say I've experienced 20 different car accidents in my life. If I get into a car accident and it's kind of like something that I'm used to, it's not something that I'm going to necessarily have a bigger response to. But let's say somebody has a first car accident, 16 years old, that event is going to be a lot more traumatic to them than if somebody who's a more experienced driver and they've had another car accident before and processed through that and was able to kind of like move forward because they know that, accidents are accidents. So with trauma, what ends up happening is when we experience an event, and the other piece of it is if we don't talk about the event, it stores in our body and it stores in our limbic system and doesn't necessarily get to be seen in a more logical way. When a traumatic event happens, your fight or flight system opens, it gets all of this information of the event. When you no longer need that part of your brain to be active, it shuts down and stores the information and the thought processes of that moment. So going back to like a car accident example, let's say two people get in a car accident. One person walks around the office and tells everybody in the office, oh my gosh, I got in this car accident and this thing happened and and I broke my leg, and just kind of going through what's happening. As they talk to each person, they're opening that part of their brain, of their system, being able to look at the information again. Frontal lobe is online because you're awake and you're not in fight or flight at that time, able to process some of that logical information. Somebody may say, oh yeah, that can happen, and this is, it really sucks, but good thing that it was a broken leg, and I'm glad everybody's okay. And, kind of however the person would kind of talk to you about it. And that information also comes in. Stop talking about it, the limbic system kind of closes, and that new information gets in. Now, same situation, but you never talk about the car accident, right? Never, ever have that experience of having that conversation for it to open and shut and open and shut and introduce new information. What then ends up happening is that event stays stored in your limbic system, and then you start to react to the world around you based on that information. So that's where we can find where PTSD sits, because when our traumas aren't reprocessed and we have a thought process or a core belief system, nobody can be trusted. The world's a dangerous place. I can't talk to anybody. I'm worthless. Things are hopeless. Whatever. I'm not enough. When those things become part of you, and you're not able to reprocess that in a different way, we then, as we move along life, we look for different instances to support that narrative within ourselves, that core belief system. So one of the challenges is being able to actually find where that original thought is, because if you debunk the original thought, the original trauma, the original event, it also can spread through to other events that you've experienced. Because if this is no longer valid, none of this is valid, or at least is as valid as you can think, you think it is. So there's multiple forms of treatment for trauma, but today we're just going to focus on EMDR. So there's 4 different types of trauma responses. A lot of people have heard about fight or flight. Freeze and fawn are also trauma responses. Sometimes when somebody experiences an event, an environment, in homes growing up, and things are very volatile, you find that as long as you keep that person at peace, you can kind of feel slightly safe. So that's where people pleasing will come in, that fawn response. Lack of boundaries, being codependent, pleasing and appeasing people's needs and not necessarily your own. Freezing is, just stopping, not being able to respond to things, going numb, dissociating, shutting down. Fight is obviously getting a physical response, maybe, yelling or actual physical interaction with somebody. Flight can be workaholics, being overthinking and just not being in your moment. OCD, panic disorders, all of those types of things can come from a flight response. So, all of these things are responses to trauma and that are affecting our lives. So until you process trauma, you may be exhibiting some of these behaviors that are in these responses whenever your body or your nervous system feels like it's in danger. Does anybody have any questions at this point? Christy's going to help me monitor the chat, but not sure if anybody has any questions yet.
No questions yet.
All right, thank you. So this is a feelings wheel that one of my individuals actually exposed me to, and I fell in love with it because identifying feelings is important. With this feelings wheel, it helps you, it divides it into when your feelings, the feelings when your needs are met and when they're not met. And then the way that it's also divided is it's divided by color in its opposite. So if you're not able to trust, you're experiencing fear. That's the blue section within this. So identifying feelings when somebody has experienced a traumatic event and trying to be able to process through the trauma, sometimes they can't figure out that fear is where they're sitting. They may be sitting in anger, which is a secondary emotion. A lot of there's something underneath that. So they might not identify fear, but they may identify, I can't trust anyone. I can't believe anybody. And so with that, with this feelings wheel, we can look at it and say, well, if we can't trust because our needs aren't being met, what's the opposite? What are you feeling in that? And so I just got this on Carolyn. Carolyn, I saw your question on where to get this. I got it on Amazon. I've got a big poster in my office here at Blue Water Counseling with this on it, and I think it's a 17 by 11 or something on my wall, and I refer to it quite frequently. So I just found this again on Amazon and was able to put this in here, but it's for sale on there, not trying to plug it, but it's for sale there, and I absolutely love it. I even bought one for my daughter to put in her bedroom. So along with feelings and emotions, we can have somatic responses. Our somatic responses are our body sensations that can be related to events. So an example can be, I'm talking about, I once had an individual who, when they smelled a certain smell, became very, very nauseous. But they didn't know why they became nauseous. So they would be out in the community doing something, smelling a smell, become nauseous. We finally, after some work and doing some EMDR on it, we finally were able to link it back to a childhood trauma that smell was associated with. And then through EMDR, we were able to process that memory. And the somatic symptom, that somatic response was no longer valid in their life. And so they can be able to smell that smell without feeling that nausea and that dread that they were experiencing at that time. When we stop and we think about events, right? Like sometimes we'll feel that gut punch, or we get short of breath, or something's in our throat, or if it was an event where we had physical harm, we may have aches or pains that are in spaces that we're like, okay, where's this coming from and why is this? I'm just talking about whatever, and all of a sudden my knee hurts. And it can be when we're processing or looking through traumas, we can go back to the original space, and that trauma can actually be identified with the somatic symptom. I have an individual who has very few memories because of their childhood, because of the traumas in which they experienced, and we actually process through somatic symptoms. Every once in a while, a blip or a picture of a memory will come up, but the somatic symptoms moves through their body and they are actually able to process. And when we look at the trigger and we look at the somatic symptom's no longer there when we look at the trigger. Although there's no idea what the event was, they just know that things had happened. They were able to process that even through the somatic symptoms. So being mindful of what our body is telling us is very, very important. So, history of EMDR. EMDR was developed by Dr. Francine Shapiro in the late 1980s. If memory serves me, when I read her book, she was walking through a garden, kind of looking back and forth, thinking about things, and actually was able to process things more effectively. So kind of like wonder if this is something that kind of spreads out. So that's where it was developed. And then by 1990, the EMDR Institute was founded, according to their website. Then there became an EMDR or EMDRIA, so Eye Movement Desensitization Reprocessing International Association. There's a website that was started in 1995, and it states there that there's over 13,000 members. Now, when you look at that membership and over 13,000 members, not everybody pays for the membership either. Like, I'm not on there. I was, but I stopped because, fees. But you can, they have the ability to track or identify therapists. So when you go on, and if you're looking for an EMDR therapist in a certain area, you can actually go on EMDRIA and be able to locate therapists that are trained in that, to be able to find somebody to get EMDR with, or when helping somebody search for an EMDR therapist. I've had people that have moved out of state that I was working with, and we went on EMDRIA and were able to link them with somebody before they even moved. So EMDR is used in multiple countries worldwide. It's an evidence-based practice, and it is something that I have seen work remarkably for so many individuals. Just kind of being a little vulnerable for a moment. When I first started working with trauma, and when I identified, which we're going to talk about in a minute, about substance use disorders, the significant link between those two, the traumas and substance use disorders, I was pretty nervous about trying to figure out how to treat that. Once I learned EMDR and I saw the efficiency and effectiveness of this level of treatment, I no longer am nervous about it because I know how it works, and I know we can treat this, and I know we can do something with that. And so that's one of the things that I love, love, love about EMDR. Does anybody have any questions? All
I have
right,
no questions yet.
I will keep going. So EMDR is a therapy that's used to assist people with bilateral stimulation. Bilateral stimulation means that there is something happening on the right side, which stimulates the left side of your brain, something happening on the left side that stimulates the right side of your brain. Left side of your brain is your facts, logic, all of the data. Right side, yes. Right side of the brain is where your creativity, your emotions, your pictures all sit. So when you're able to stimulate both sides of the brain, you're able to look at the entire picture. So with EMDR, we're doing that to look at the entire picture. In addition to that, in thinking about the event that we're processing at that time, your limbic system opens up because you're thinking about a trauma, right? So that part opens up, and then your logic is online because you're awake. One of the challenges, people will try to process things while they're asleep, subconscious mind trying to figure out the day and how the world's working. So your subconscious mind is trying to process that, but one of the hard things is your conscious mind is not online, so you can't look at it in a different way. So that's what EMDR gives you the benefit of. It kind of stimulates REM and simulates REM. And with simulating REM, it allows you to, again, interact with all these different parts of your brain. In working with EMDR, one thing that we have to be mindful of is the person that is processing. They have 1 foot in yesterday and 1 foot in today. So you need to make sure that they're present enough to not completely go into a flashback, but able to connect enough to be able to re-experience, at least on some level, what the trauma is. So I have right here, I have the tappers. I have a picture of them, but right here I have my tappers. So they're just 2 little things that you can hold on to, and it connects to this little box. And this little box, I can control the intensity, the speed, and the length of the vibration for people, because some people are more sensitive, and some people not necessarily, to touch or they can to that stimulus. So what we do is we don't want to get them overstimulated, so we don't want them to vibrate too fast, but vice versa. You want to make sure that the person is able to feel that and experience it. With EMDR, there's an 8 phase approach. Phase 1 is about history, kind of getting that case conceptualization and treatment planning. You're talking about the history. You're making sure that the person is on board for EMDR and that they're ready to be able to do that. That somebody, to get an idea if the treatment is appropriate for the individual, because we don't always necessarily have that. Because some people, if they dissociate too much, there's more preparation that's needed. And also, the therapist should be trained on how to work with dissociation in EMDR, because again, you have a foot in yesterday and you have a foot in today. And if somebody dissociates a lot, they could go straight into yesterday, and you can have what's called an abreaction, which is a extreme emotional response because the person is so intensely in yesterday. So when working with dissociation, you really need to have extra trainings to be able to understand how that works. Preparation is, we do resourcing. So we create a safe space in your mind, some place to kind of go, close your eyes and be. So it can be real or imagined. Mine is at Disney World. I always like to talk about that because it's like, it was a place that I found at peace at a certain spot, and it's one of my favorite places. So going there in my mind makes me extremely happy. And so it allows me to, if I need to kind of take my emotions and regulate them better, I'm able to take that and de-escalate where my emotions are and able to go there. The other thing that we use is a container. A container is a place in the mind that we can store the emotions when we're not working with them, to store that distress. The most popular one that I have found is like a vault, and people will have either multiple vaults or they'll have safety deposit boxes in their vaults, because we want to not only be able to store the distress or store that pieces of those memories, but we also want to store them individually, because we don't want to, when you open the vault, all of it's there, right? We don't want to open Pandora's box. We want to be able to go in and address the one thing that we were addressing for that day. So in the assessment, phase 3 is the assessment level. The assessment level is kind of preparing for desensitizing or doing the actual process of EMDR. So phase 1 is usually a session in itself. Phase 2 is a session in itself. I actually flip those a lot of the times, because if somebody's experienced significant trauma, I like to be able to get their safe place and their container in place before we start making their trauma timeline, before we start looking at all of it. I want to be able to kind of take that and be able to put it away. So assessment is when you look at the memory, and we're going to get into some of the terminology. So I'm going to flip to the terminology and then I'm going to come back. So in the terminology, it talks about, these are a lot of the things that you're going to talk about in the assessment piece. So BLS, bilateral stimulation, is that vibrating back and forth, or eye movement back and forth, or sound back and forth, in order to be able to do that. To be able to reprocess. Body scan is going from the top of your head down to your toes. What are you experiencing? That's where you feel like the sensations in your chest, arms, hands. I've had people where their legs wanted to run, and so because of the memories in which they're experiencing. So you're noticing where that disturbance is, and you're writing that down, because you're going to have to check back after they've reprocessed to make sure that that's gone. Negative cognition. What do you believe about yourself when you think of this target memory? I'm not safe. I'm a bad person. I'm not enough. I'm worthless. I'm unlovable. I'm unlikable. Like, I have a whole list of different things. I usually don't hand out the list because it's a whole lot of selection, and people usually can pick out like 5 or 6. So just kind of looking at and talking with and with experience, I'm able to kind of narrow it down to get that negative cognition. Positive cognition, that's what do you want to change your mind to? So I'm not safe. So do we want to look at the world's not completely dangerous? Right. And we want to make sure that it's a valid statement. So we can't say the world's a safe place because there are times where the world is not safe. But the majority of the time as adults controlling our own environment, doing things that we can do when when we're in control of them, we can try to create a safer environment for ourselves. And that's how we can transition that positive cognition. So I'm going to jump down to VOC, validation of cognition. So we look at the positive cognition, and we say on a scale of 1, completely false, or 7, completely true, how true does this positive cognition feel to you right now when you think of this memory? So we can kind of see on how much movement needs to go to create that positive cognition to be a truth. The positive cognition is something that can change. So that's something to be mindful of. The negative cognition cannot change. The negative cognition actually drives where the memories are going to go. It's going to drive your processing at that time. So the resource development is like what I was talking about. These are your container, your safe space. I had an individual who had an animal that went along in their journey because they needed that support. So as they went processed through, they had this animal that represented courage to them to be able to walk with them in their journey of healing. So there are also other types of resources that can be created. It's not just those two, but those two are core ones that we do create. A set is going back and forth, how many times it goes back and forth. It says a set 24 or more. I usually do anywhere between 30 and 35 in order to allow the person to be in their thought process, which means that when you go to do EMDR, you bring up the memory, we look at the negative cognition, notice the body sensations, and you say, go with that, right? Like, so it's kind of pressing play on your home movie to be able to look at the trauma in which you experienced. When you do that, they're doing that in their mind. They're doing that within themselves for a couple different reasons. One, sometimes people don't want to give you all of the information, and that's okay. That's the one thing I love about this too. You don't have to give me all the details. I always tell people, I am willing to take any detail that you would like to give. I'm okay with that. And also, if you don't want to give that information or all of the information, I'm okay with that too, because you're going to be processing that. Another piece of it allows them to go through memories. Sometimes people will have flashes of a bunch of different memories related to that negative cognition that allows them to be able to not only process the memory or the trauma they experienced, but other things that have validated that negative cognition. So it's absolutely fantastic to see when you go through their history again, hey, let's look at what memories we want to do next. And they're like, oh, nope, there's nothing on that one either. And, you're not knocking off like 5 different things because we processed something last week and all 5 of those became resolved. Subjective units of distress. It's a scale of 0 to 10. The distress in which we experience is subjective to our own spaces and our own life experiences and our own emotional responses. So we use SUDS because I can't tell you how you experience that trauma because trauma itself is subjective. So looking at it on a scale of 0, no distress at all, 10, as much disturbance as you can experience, where are you at right now when you think of this memory? And so that's part of what we have to get in place. Your target memory is where we start the session. Tice's worksheets. I'll talk about those in a minute. This is a worksheet. I actually was going to have this scanned in, but I'll get it scanned in and sent over to Christy if you would like it. And what that does is it's over the week. looking at what triggers you had. What did you imagine? What are your thoughts? What emotions? What sensations do you have in your body? Where are your suds when you think of this? Then what is the intervention or coping skill that you did? And then after that, what are your suds? So the TISES worksheets are for, when we process something, what has your week held? Cognitive interweave, that because the therapist is more passive in the processing with EMDR, there are rules that the therapist still has to have, and you still have to pay attention. You still have to be fully engaged with your individual, because like a cognitive interweave, sometimes if somebody's stuck in a thought, you can interweave like, well, what if you think about that differently using Socratic questioning, right? What would it be like if you were able to see it from the other person's point of view and allowing them to process with that? Okay, go with that, and allowing them to start that with the processing. So I'm going to go back really quick. So when we go to assess, we're looking at the target memory, negative cognition, positive cognition, VOC, SUDS, doing a body scan, and what emotions you're experiencing. We take all of that information and then we say, okay, with thinking about your target memory, thinking about your negative cognition, notice any disturbance in your body, and go with that. Press play on that home movie so you can start to look at that trauma. Once you're done with that, we do what's called an installation. So what thought did your negative cognition move from to? Revalidating the positive cognition or changing the positive cognition, and making sure that we use a slower bilateral stimulation, slower with the tappers back and forth, for you to be able, for that person to be able to really make sure that that memory is linked with that positive cognition and not that negative cognition anymore. Doing the body scan, if you notice any disturbance, you go back in and you process again. You go back in and you start to, because obviously, as I said, you can process just somatic symptoms. So if there's a somatic symptom still sitting there, we need to know what's still holding on and how we can change that. Closure is just making sure that everything's okay in that, and then reassess is next session. Let's bring up that memory. Let's look at, scan your body. Let's look at your suds. Where are you at? The hope is always to get to 0. So your suds going from whatever number to 0. I make it sound quick. Sometimes it is, sometimes it's multiple sessions, and you're using that container and safe space to get from week to week. Are there any questions? That's a whole lot of information.
Yeah, we have a few questions.
Okay.
I think you kind of discussed this already, but it says how many sessions of EMDR does it take to be effective, and does it have to deal with one trauma at a time?
You start, so it takes however many it does. Again, sometimes you can get it done in one, sometimes you can get it done in more than one. There's a lot of components to that. Like if you're looking into or knowledgeable at all about parts work, sometimes there's a part of us that doesn't want to let go of that. And so sometimes that slows down processing. Sometimes if the negative cognition is a very reinforced negative cognition, sometimes it takes a few times to be able to change that through. But what was the second half of that question?
Does it have to deal with one trauma at a time?
It we start with one trauma. You have that target memory. So yes, you start with one trauma, but there are so many times that there are like when we go through the trauma timeline list, nope, that doesn't, nope, that's not. And so we're able to, I had one person describe it as, I'm standing here looking at a collage of traumas that are related and crossing them off in my mind. And I thought that was like the best visual that somebody could give me to understand what they were experiencing at that time.
Okay, and another question. Aside from disassociation, are there any specific diagnosis someone could have that would make EMDR not conducive for someone's well-being?
Um, so yeah, DID gets a little challenging. Again, it's more about specialized training. It's not that you can't do it, it's just you need to make sure that you know how to do it. Don't be an inexperienced person and work on that. The same thing with psychotic disorders. You have to make sure that you um have a specialized training to be able to understand that even if somebody's trauma is linked in a delusion, um it's their truth, so it's still their trauma, and working with that, and being able to maneuver through that system is a little more challenging. I'm going to talk about in a minute with substance use diagnosis. There are specialized training for that. There is, oh gosh, there are books. Do I have one in here? Yes. There are multiple books like this that are the scripts for EMDR therapy. So, like this one is for treating anxiety, obsessive compulsive, and mood related conditions. So, it's this this huge book is just scripts for that. There are multiple scripts for all kinds of different things. So once you learn general EMDR, doing trainings and finding out how you can work with other things, or again, it's a very scripted set things, so type of therapy. So you can actually go through the scripts, just be familiar with them while working with somebody. Did
We
that
have
answer it?
one more. I think so.
Okay.
We have one more. Do you have experience with tactile EMDR? Would you speak on it? If you do, please.
Can you elaborate on what tactile EMDR is? Like using the tappers or tactile somatics?
We'll give her a minute
Okay.
to respond. But someone else said, "Where do you get the books with the scripts in them?"
Amazon. It's a great resource. I hate to keep plugging it, but it really is a great resource. And so if you just put in EMDR scripts, it gives that like a whole list of different ones. I have 3 of those books. It's just 2 of them are at home for some reason, and then I only have the one here. So if somebody, I think I saw if they were visually impaired, yep, you can tap, like you can use your tappers, obviously. So these, because these vibrate back and forth, right? So just it goes back and forth. If you don't have um, if you don't have tappers, you can tap on your legs. I've been told like some people will just do this for tapping back and forth. You can also use auditory. So my system here, I have a pair of headphones that you can link with that. And you just put in the headphones and the sound goes back and forth. If you don't have that on a system, they actually have bilateral stimulation on YouTube for videos for auditory bilateral stimulation. So pretty much anything that you can get it back and forth, that's ultimately what you want. And if you're reprocessing a memory, it's a faster pace than if you're not. Uh, So I just saw something about Pessy.
Yeah, is
So
any did you see the question or you want me to read it?
a little bit.
I'll read it just real quick. Is
Thanks.
any EMDR training okay? I was trained through PESI. Is it ethical for me to practice it without that in-person training piece? I am a LPC, it says.
So EMDR, as long as it's an EMDRIA certified training, that is going to be an appropriate training. I'm not as familiar with the PESI program or their what their EMDR system is like, but EMDR is you look for something that's an EMDRIA identified or appropriate approved. That's the word I was looking for. An EMDRIA approved training. So you can, and EMDRIA improved trainings can either be online or in person. So it does not have to be an in-person training. It can be an online training. It's set in two sections where the first section of training is like basically what I just kind of ran through. The second set of the training is like, what do you do if something goes sideways? And so if somebody has an app reaction, if somebody's experienced dissociation, if somebody, that's the second half of the training. So I did a 5-day intensive. So I did all 5 days at once, did part 1 and part 2 at the same time. The other piece about an EMDRIA approved training is you will get consultation afterwards. I think I did 10 or 20, I can't remember, hours of consultation after after the initial training. So you go forth and you start using EMDR, and then what you do is you sit down with somebody once a week, and it's a group consultation. And kind of go over what did you experience, what did you learn, what do you need to know more about, and going through all of those types of things. So if PESI didn't necessarily have that component, I would encourage you to find a way to at least get that, if it gives you the whole set of information. If it didn't give you the whole set of information, I would really look on EMDRIA. It has list all of their approved trainings. And in order to become a consultant, when you're first done, you're EMDR trained, and then you do so many hours of training and working with somebody one-on-one and also in group, and then you can be certified. That's where I'm at. And then after that, you do, again, so many trainings and working with people and like being a trainer in training. And then you can be a consultant after that. So it's a huge process in order to become a consultant through EMDRIA. And that's very important to make sure that you have somebody that's really supporting you through it, because there's a lot of questions that come up at first. So all right, I'm going to get moving forward if there's no more questions.
No more questions.
All right, so who can provide the EMDR therapy? Just kind of explain that. It's that specialized training. It can be 5 to 7 days, depending on how the person has it broke up, whoever the consultant is, and how that works for them. But you have to ensure that you're like that EMDRIA approved training. Multiple diagnoses, you don't necessarily even just have to have, I love EMDR, because what I'll do is I'll get somebody set up with EMDR, we'll process a trauma, and then I can't tell you how many times I'll throw tappers at somebody and be like, they're having anxiety about something. Let's process this. Here's the tappers. Even talking with the tappers going can stimulate both sides of your brain. And that is something that I will do with people, especially with like the person I said that does just somatics. By the time their protector is so strong, so they have a protector part that is so strong. And so by the time that we would turn off the tappers, and I asked her what she noticed, she'd forget it all. So I just had her talk through everything that you're feeling. Close your eyes, notice the somatic symptoms, but tell me, don't wait, because that way I was able to follow her journey. And there's been a lot of times, like there was one memory that was revealed, but they don't even remember remembering that, but they were able to give me the information before the protector really kind of cut that off, building a wall to make sure that this person is protected from all of the abuse that they experienced. So there's multiple different things. Again, those books are assistive on that because chronic illnesses, depression, bipolar, diagnoses, dissociative disorders, grief and loss, pain. There's a whole list of things that people may be experiencing that you really can use EMDR to assist with. So EMDR and substance use. So getting to the core, there are four different types of therapies that are used for substance use disorders. CRAVEX, which is Craving Extinguished Approach, that's developed by Michael Hayes. This approach is reprocessing the addiction memories. And ideally results in being able to reduce the cravings. With CRAVEX, you have to be able to stop use prior to using that type of therapy. The next one is FSAP, which is Feeling State Addiction Protocol. This is developed by Robert Miller. The protocol involves identifying the parts of the addiction experience that feels good. And so being able to pull that out to be able to wish that or create a desire to stop that, because the pleasure parts of our brain get stimulated when we are using substances. So that's one of the hard parts of not using is, necessarily not being able to experience what they experienced in that. And so allowing you to no longer have that craving or have that that experience, being able to pull back from that. This other one it's an intervention of addictions. It's a concept developed by Marcus and Hornsleb. I'm not as familiar with this one. It provides a framework for understanding EMDR and addictions treatment, and that's the aim of that. It's more of a trauma-focused EMDR or addiction-focused EMDR. I'm going to actually focus on a different training. It's a training that I use, but the reason why I chose that training to use is because Detour, which is the training I'm going to talk about next. Detour allows somebody to still actively use and also be able to get the treatment for and using EMDR for the cessation of use. So one of the bigger challenges is with working with substance use is it's the chicken or the egg, right? Usually the trauma came before the substance use, but sometimes when somebody is active in their use, traumas can happen. And so it's having to treat both through EMDR. And so really looking at the priority, really looking at the barrier of the processing of traumas, how the use would affect that to ensure that it's an efficient modality of treatment. So looking at which one needs to come first, because people struggle because they use to forget, they use to escape, they use to be able to get away from the traumas in which they've experienced. And so asking somebody without treating their to be able to stop use, asking them to stop use to be able to process the trauma. But the other side of it is if asking them to stop using, but never processing the trauma. So you really have to use your clinical judgment on which you approach first, because you can't necessarily do them together. So Detour is desensitization of triggers and urge reprocessing. It was developed by Dr. AJ Popke. I was lucky enough to be able to watch the training. When I was trained in this, he actually presented it. So he unfortunately passed during COVID. So he's no longer here, but he did a lot of research, a lot of study. One thing that he says is he had yet to, in his career, yet to find somebody that had a substance use disorder that didn't experience trauma. And so how he talked very much about how those two things go hand in hand. So with this protocol, it focuses on taking away the triggers or desensitizing the triggers to reduce the cravings. Um, it's really kind of focusing on a positive target, imagining what your life would be like, making that bigger, making, kind of creating a reality within the processing of what life is like without use. They started it with cigarette cessation to stop nicotine use. And one of the people that he was processing with, um, he was processing to stop smoking and kept processing to stop smoking. The person continued to use cigarettes, but stopped smoking heroin. So they were like, oh, this is kind of universal. So that's kind of where that got developed to be able to be universal. Because again, they stopped smoking, but they didn't even mention that they had been using heroin. So it was a very enlightening situation in the way that he described it. And so that's when he started doing more research on what all can this be beneficial of with. So it resources your internal states. So like how you're feeling, what are you focusing on? How does it feel inside of you? What are you experiencing? Instead of an external memory like we would do for reprocessing through EMDR. So you're looking at a positive resource that you're working towards to, again, imagine what a life is like without. What does it look like if you're not using? What would you want your life to look like? How do you design it? What's getting in the way of that? There's a whole script that is written on how to go through that. Instead of processing SUDS or your subjective units of distress, you instead use a level of urge. So as you go through and with EMDR, you would ask, where are your SUDS at right now? Scan your body from head to toe. Where are your SUDS? And as they process along, you shouldn't do it too often as you're processing, but once or twice as you're processing through the memory, you're going to ask because you want to make sure it's going in the direction of lowering. So as that's processing through, you're doing the same things, but where's your urge at? Where are you at in when you're thinking about using? How is it feeling? How is it feeling to try to picture that life that's outside of use, what that can look like? So instead of looking at your traumas, you're targeting your triggers and urges. So the resource is that life without. You're focusing on what are your triggers. So when you start off, it's like, what are your triggers? Where is your level of urge? So is it the smell of something, the sound of something? Is it going to certain places? Is it, what's creating that trigger to want to use? And when whatever's creating that, that's what we process on. And then again, watch that level of urge decrease. And that's how we process using the detour. And I, again, really like detour just because, well, for a couple different reasons, but one of the main reasons is somebody still can be active in use, and we can also treat with using bilateral stimulation when somebody is active in use. The only stipulation is they can't be high when you process with them. So you can't come in high, you can't come in drunk, but you don't have to stop using. If we need to, we'll just do a morning session. We'll do, whatever accommodates you to be able to allow you to be abstinent at the time of processing. Any questions?
Yes. How do you determine if this is an appropriate methodology for someone to address their issues? Can someone contact you as a new client and ask for these services from you?
Yes, I start people off from straight with EMDR if that's what they're looking for. I also collaborate with some of my colleagues. So my colleague will be doing general therapy, and I would be doing the EMDR for the person to allow general therapy or to be able to continue. And EMDR goes faster if you can just focus on EMDR. One of the challenges is if I'm doing EMDR and also just general talk therapy. Sometimes life happens. Also, avoidance happens. Looking at your things in life that you didn't want to talk about, you can always detour because this happened or this happened or this happened this week, and try to not process that week. So I like the collaboration more, but yes, they can just come in as an EMDR client.
All right. And when using tapping in session on legs or with fingers to activate both sides of the brain, is this a safe practice to use if not EMDR trained to assist the client in processing trauma without EMDR?
There is There are studies and there are other methodologies that do use bilateral stimulation. I cannot encourage, but I also won't discourage that. I would just ask you to research that before you do utilize it in therapy. There is a thing called, oh, good golly, what is it called? I can't remember it. Oh my gosh, I'm totally going blank. I'm trained in it. Um, Shoot. But it uses bilateral stimulation in creating like a capsule, and it uses a positive thought process. So, like, you take your trauma, you put it in a capsule, you separate yourself from the capsule, use bilateral stimulation to talk about a very positive memory, and it helps replace the distress related to flash. That's what it's called, flash. And you use that to create a positive memory to kind of replace the distress. It's a very interesting therapy, but it's something you don't have to be EMDR trained in, and you can also just get the training in Flash. So and that's something that it's a lot less expensive to be able to do and still utilize. So hopefully that answered. Christy, is there any?
I think that's all the questions for now.
Okay. So yeah, so using bilateral stimulation is very assistant. It's just, again, research something or at least take a training to understand. Okay. Um, so thank you so much for having me, and thank you so much for attending today. Christy will be able to send out the copy of the PowerPoint. But Christy, I'm going to get a scan of this TICE's worksheet first to you to be able to send both if you could.
We actually did have a question. Someone was asking, where do you get this information from on these SUD EMDR methods and training?
I went on the EMDRIA site and that's where I found it. Because it is a protocol for EMDR, the EMDRIA site, they have a ton of different trainings on there, and both in person and also where they're virtual or recorded. And the thing is it's like everything, right? Like, so you can find trainings on working with dissociation, working with psychosis, working with substance use, there's a training for working, it talks about IFS and EMDR. There's a training on that. So there's a ton of trainings. Just go to the EMDRIA website and you can find them there.
All right. Thank you very much. I was just kind of trying to go through all the chat to make sure we didn't miss anything. There's a lot of thank yous in there and awesome trainings. Thank you so much. A lot of people just said thank you for all the resources and information. And we just want to thank you for coming and sharing all your information and time. I want to also thank everyone that joined today. We hope you found the information valuable. Today's presentation is just one of many webinars being offered throughout September as part of our Recovery Summit. For details and registration for upcoming sessions, please visit our website at www.sccmh.org under the Events tab. Also, keep an eye out for a short survey in your email. Your input is vital in helping us continue to improve and shape future events. For those requesting a MCBAP and peer certificates, they will be emailed out by mid-October. If you're requesting social work CEs, your certificate will be emailed to you after payment is received, if applicable. Thanks again for joining us today. Thank you again, Shannon. We look forward to seeing you next time and hope you have a great rest of your day.